Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary. For the medical knowledge to general people and for reference to medicos. Today I am going to discuss about the urethral stricture. Urethral stricture is the narrowing of the urethra and difficulty in passing urine. It may be congenital, traumatic, inflammatory, instrumental and post-operative. Congenital stenosis, meatal stenosis. The external urinary meatus is the narrowest part of the male urethra. Congenital stenosis is usually associated with the phimosis. Treatment: meatal stenosis causing symptoms, prevent free drainage, obstruct the passage of instruments or a cystoscope, should be treated by meatotomy. Lesser degree of narrowing respond to dilatation with Hagar's dilators. Meatotomy: a fine pointed scalpel introduced into the urethral meatus and a cut is made in the downward direction. In infants and children, a meatal bogey of a suitable size is passed into the meatus each day for 4 days and then weekly for 1 month. Traumatic: may be bulbous or membranous. Inflammatory: may be post-gonorrheal, post-urethral chancre or tuberculosis. Instrumental: may be due to indwelling catheter or following the passage of a large caliber endoscope like resectoscope. Post-operative: post-operative prostatectomy or amputation of penis. Post-gonorrheal stricture: it is rare these days when occurs, mostly found in the bulbous, penoscrotal junction and distal part of the spongy urethra. The prostatic and membranous urethra is not affected. Multiple strictures are relatively common. When there are 2 strictures, the deeper is the narrower. When there are 3 strictures, deepest is the narrowest. If the stricture in the penile urethra has a narrow orifice, there is seldom another stricture behind it. If gonorrhea infection is neglected, persists in the periurethral gland and spreads to periglandular tissues, infiltrates with round cells and fibroblasts. The periurethral tissue contact with formation of scar tissue, localized thrombophlebitis of the corpus spongiosum playing a part in dense types. In the bulbous urethra, the fibrosis is most in evidence in the roof. In the penile urethra, it predominates in the floor. Structures develop in the first year of infection, but symptoms develop after 10 years. Clinical features: in stricture of large caliber, occasional passage of plaques, discomatous epithelium and urethral discharge, gleat. The morning dew drops, difficulty in micturition, necessity to strain for urination. The stream becomes progressively narrower. Micturition is prolonged, end in the dribbling. Frequency during day, first and then night as well. Stricture may be palpable as induration on the urethral floor. A retention of urine may be acute. Urethroscopy: here the stricture is seen as a white scar of fibrous tissue and its position in the urethra. The size of its contained lumen and its dilatability can be judged. Sometimes the stricture encircles the whole of the urethra and the lumen is centrally placed. Urethroplasty reveals the length of the stricture, dilatation of the diverticulum, formation above the stricture or failure of medium to pass a stricture. Instrumental treatment. Intermittent dilatation. Dilatation at suitable intervals is a satisfactory form of treatment. Before each dilatation, the patient should pass urine. The glands and the urinary meatus are cleaned, and the urethra is filled with a mild antiseptic solution and local anesthetic in a methyl cellulose base. Dilatation must be carried out gently with bogies of increasing size. Overforce or overdilatation results in trauma. The cured patients must be kept under supervision. Gum elastic bogies, French bogies. These are the standard instruments in early stages of treatment of all but the fine strictures. It is commenced with the number 10 French and proceed with smaller numbers. Even filiform bogies are employed. Filiform bogies. These are gum elastic bogies varying in size from 1 to 3 French. If one fails to pass, it valuable to pass several as far as the stricture. By manipulating each back and forth frequently, one of them can be induced to negotiate the stricture. To distend the urethra with sterile oil and apply a penile clamp to the glans penis prior to the attempting the foregoing method adds to the chances of its success, because the obstructing folds of mucous membrane are separated by the oil distension. If this fails, it is possible to pass filiform bogie through the stricture under the vision afforded by the urethroscopy. Filiform bogie with followers. Filiform bogie furnished with threaded hollow mounts at their proximal ends are to be preferred, because screw-ended elastic bogies of large size can be attached and guided by filiform through the stricture. In this way, strictures of very small caliber can be dilated. By means of gum elastic bogies, a stricture dilated up to size of 14 French. Lister metal bogies, English bogies, indicated after second or third attendance of a patient with stricture responding to dilatation. Continuous dilatation. It is of benefit in case where little progress is made by the intermittent dilatation. After dilatation with gum elastic bogies, a catheter of corresponding size is tied into the urethra, and its removal 2 or 3 days later, it will be found possible to pass much larger bogies. Operative treatment. External urethrotomy. Wheelhouse operation. It is preferred when there is acute retention of urine and the stricture is not accessible. The patient is in lithotomy position. The wheelhouse staff is passed down to the face of the stricture and the urethra distal to the stricture opened by cutting down onto the groove in the staff. Stay sutures hold the edges open to display the face of the stricture. The midline incision is then carried backwards till the dilated proximal urethra is opened. Urine will leak out under some pressure. A catheter is now passed from the external meatus across the opened urethra into the bladder and the wound packed lightly. Alternatively, the operation can be concluded formerly as the first stage of urethroplasty, by stitching skin edge to mucosal edge. Internal urethrotomy. These days it is rarely performed when the stricture is possible. A triangular cutting knife runs in a grooved staff which is guided through the stricture by a fine gum elastic bogie. The stricture is divided by sharp thrusts of the knife. Intermittent dilatation by bogie should be commenced 14 days later. Urethroplasty. For bulbar and penile strictures, treatment of choice these days is urethroplasty, Johnson's urethroplasty. The circular constricting tissues should be completely divided and the urethra is opened at either end of the distance of about 2 centimeters. Skin and mucosal edges are united to prevent the urethral edges from rejoining. Contraction of the damaged tissue and the incisional scar will occur, but 3 months later, employing the principle used in the Dennis Brown repair of hypospadias, a strip of skin which has been obtained a blood supply from deep tissues and the residual urethral wall can be buried to form a new penile urethral distal bud. A funnel of scrotal skin will have to be used to reach the upper end of the urethral defect. Complications of urethral stricture: retention of urine, urethral diverticulum, periurethral abscess, urethral fistula, back pressure, hernia, hemorrhoids and rectal prolapse. That's all about the stricture of male urethra, and in the next video I will discuss about some other disease. Thank you.